Now, in the past, there was huge controversy regarding the relationship between double inlet left ventricle and tricuspid atresia. And I intimated to you on the first day of the course that one of my worst moments was when I tried to persuade people that tricuspid atresia was a univentricular heart. Now, you might wonder why I even wanted to tell people, or why I wanted people to believe that tricuspid atresia was a univentricular heart. And the reason for that was that I'm showing you at the moment a picture of classical tricuspid atresia. And at that stage, everybody recognized that this chamber was a right ventricle. And you can see that it has an apical trabecular component, it has a long outlet component that's extending up to the normally attached pulmonary trunk, and the pulmonary trunk and the aorta spiral as they leave the heart, so-called normal connections. And the problem we had come across was that we'd encountered this heart. Now, Andrew has already shown you this heart with the television camera, and you know that in this heart both atrioventricular valves connect to the dominant left ventricle. But when I looked at this heart from a patient known to have double inlet left ventricle, I could not see any morphologic difference between this chamber and this chamber. But sadly, at the time, 1977, I was a bit dumb, and my colleagues were unable to persuade me otherwise, but I said, if everybody is calling this thing an outlet chamber and is saying that double inlet left ventricle is the paradigm of single ventricle, then tricuspid atresia is obviously single ventricle as well. What I should have said was, come on, you dummies, you all know that tricuspid atresia has one big ventricle and one small ventricle, so double inlet ventricle obviously is not a univentricular heart. But I wasn't smart enough to think of that at the time, so sadly I tried to promulgate the notion that tricuspid atresia was a univentricular heart. And amazingly, lots of people agreed with me, which just shows you can fool some of the people all of the time. But there were people who were sufficiently bold to tell me I was ridiculous, which was indeed the case. But nonetheless, as you see, when you have concordant ventricular arterial connections, it's nigh on impossible, simply by looking at the incomplete ventricle, to tell whether there is double inlet or absent atrioventricular connection. And it's with the fullness of time that we came to appreciate that the difference between double inlet left ventricle and tricuspid atresia was that in double inlet ventricle, as you know, both atrioventricular junctions join to the dominant ventricle of left ventricular type, whereas the essence of classical tricuspid atresia, as you see in this four-chamber section, is that only the left atrium joins to the dominant left ventricle and the right atrioventricular connection is absent. And rather than the ventricular mass being univentricular, it is the atrioventricular connection which is univentricular. So in 1984 we had our Damascene moment, and we admitted to everybody that we had been totally wrong when we suggested that tricuspid atresia was a single ventricle. But by the same token, if tricuspid atresia was a biventricular heart with univentricular atrioventricular connection, then so was double inlet left ventricle. And that for us created logic. As I say, there are still those, notably in Boston, who argue that double inlet left ventricle is a single ventricle because they want us to believe that the incomplete right ventricle is no more than an infundibulum. But again, this is an egregious breach of the morphological method, and as you all know, the morphological method emanated from Boston. So it's a situation of don't do what I say, do as I do, but we don't. So there we are. But what we also have to appreciate is that although the classical variant of tricuspid atresia has unequivocally univentricular atrioventricular connection, we can also get tricuspid atresia in the setting of imperforate valves. And we've discussed this conundrum previously in the course, and now I can illustrate it to you, because it is true that imperforate valves can produce tricuspid atresia, but moreover that imperforate valves can be found in the setting of both univentricular and biventricular atrioventricular connections. Now you may not quite understand how that can be, so bear with me and I'll take you through this. Because the essence of analysis in patients having atrioventricular valvar atresia is to distinguish between the connections across the atrioventricular junctions, morphology of the ventricular mass. So by now you should be coming familiar with this particular picture. It's an exquisite picture. It's one of the hearts that I sectioned whilst I was still at the Royal Brompton, and any of you who have been on Dr. Ho's hands-on course may well have seen this sectioned heart. But you can take any heart with classical tricuspid atresia and you can produce sections like this, and you know you can do exactly the same thing with cross-sectional echocardiography, because the essence of tricuspid atresia is that the right atrium has no connection with the ventricular mass. There is absence of the atrioventricular connection. But I've also shown you this picture before, and this heart is from a patient who had pulmonary atresia with intact ventricular septum. And we're going to talk about pulmonary atresia with intact ventricular septum after we have had our lunch. And in most instances, the tricuspid valve is patent in the setting of pulmonary atresia with intact ventricular septum. But in certain circumstances, the valve can become so stenotic that there is acquired atresia. And that is what you are looking at here, because you see that the right atrioventricular junction is formed, but the valve has become imperforate. So it is blocking any passageway across the atrioventricular junction, and the only way that the blood can get into the ventricle is to cross the atrial septal defect, enter the left atrium, and thence go into the big right ventricle. So here we have a dominant right ventricle, we have a dominant left ventricle, we have a complete right ventricle, but a complete right ventricle which is rudimentary. And so we can have tricuspid atresia also in the setting of biventricular atrioventricular connections, and in both instances the hearts are functionally univentricular. So when we describe functionally univentricular hearts, we are not necessarily talking all the time about atrioventricular connection. And let me now compare for you this heart, which you saw just a moment ago, and which I explained to you, had an imperforate right atrioventricular valve in the setting of biventricular atrioventricular connections. Compare it with this heart. Now I need to take you through this heart and show you what is happening, because you are looking here at a ventricular mass in which the left ventricle is dominant. And you see the right atrioventricular valve is perforate, but the left atrioventricular valve, also joining into that dominant left ventricle, is imperforate. And it is a herniated mass that is protruding into the big left ventricle. And again, there is an incomplete right ventricle that is positioned anterosuperiorly and leftward within the ventricular mass. So here we have an imperforate left atrioventricular valve in the setting of double inlet ventricle. So we can also have imperforate left valves when we have univentricular atrioventricular connections. The point being, we have to describe precisely the atrioventricular junctional morphology, and we have to distinguish that from the ventricular morphology. So in this instance, both of the hearts again are anatomically biventricular. The one to your left hand having concordant atrioventricular connections, the one to your right hand having double inlet left ventricle, and both again are functionally univentricular. So we have to be precise in our choice of words to describe these complex genitally malformed hearts. So having established our ground rules, let's now come back and look at a little more detail at the variants of atrioventricular valvar atresia. Now, without question, the commonest form of valvar atresia is tricuspid atresia. In 9/10 of instances, that is going to be produced by absence of the right atrioventricular connection. And you all know that in that setting, the ventricular arterial connections can be as variable as they are in double inlet left ventricle, with the crucial difference being that when we have tricuspid atresia, it is much more common to find concordant ventricular arterial connections and less common to find discordant ventricular arterial connections, whereas the reverse is true when we are talking about double inlet left ventricle. From the point of clinical presentation, the size of the ventricular septal defect becomes crucial, and again we must remember the associated defects. But we must also remember that tricuspid atresia can be produced by an imperforate tricuspid valve. It's much rarer, but it does exist, and when found, it's typically seen either with Ebstein's malformation or, as I have shown you, in the setting of pulmonary atresia with intact ventricular septum. And then almost always the ventricular arterial connections are concordant. So here is the right atrium in classical tricuspid atresia in a patient with concordant ventricular arterial connections. I'm showing you the floor of the right atrium. There is no evidence whatsoever of an atrioventricular junction. There is a dimple, but that dimple is not the atrioventricular valve. In fact, it overlies the atrioventricular component of the membranous septum, and if you push a pin through that dimple, you go not into the incomplete right ventricle, you go into the dominant left ventricle. So you need to distinguish that from hearts such as this. I've cut away the wall of the right atrium. You can also see here that there's a grossly dysplastic pulmonary valve, but this is what I want to draw your attention to, because this is a herniated right atrioventricular valve, but you see that there is a right atrioventricular junction, and that is going into the hypoplastic right ventricle. So there we are dealing with an imperforate atrioventricular valve, and so this is the rarer form of tricuspid atresia with concordant atrioventricular connections. But it is the size of the ventricular septal defect that is most important, and typically when we are dealing with concordant ventricular arterial connections, the ventricular septal defect is restrictive, and that is obviously going to restrict the forward flow of blood to the lungs. In this instance, with concordant ventricular arterial connections, we have an unrestricted VSD. So in this patient, there will be pulmonary plethora, and if you are contemplating treating the patient, you would need to band the pulmonary trunk as the first stage of treatment. So that's the situation with concordant ventricular arterial connections, where restriction of the ventricular septal defect cuts down the amount of blood getting to the lungs, Obviously, if you have discordant ventricular arterial connections, then the size of the ventricular septal defect is going to dictate how much blood goes into the systemic circulation. And in this instance, there is isthmic hypoplasia, but it's also the case that the more restrictive the ventricular septal defect, when you have discordant ventricular arterial connections, the more likely you are to have severe aortic coarctation or even interruption of the aortic arch. So, obviously, the restriction of the VSD is interrelated with the ventricular arterial connections in the clinical presentation. You need also to remember that absent atrioventricular connection can be found when the solitary atrioventricular valve straddles, and that gives us that rare but interesting creature, the uniatrial but biventricular connection. You've already seen examples of that, and I'm sure Andrew is going to show you examples again. And then when we talk about absent atrioventricular connection, we have to revisit the conundrum that we've discussed on several occasions during our course. If we have absence of the left connection and the right atrium connects to a dominant left ventricle, should we call that tricuspid atresia or should we call it mitral atresia? And as you know, my own preference is to not put a label on it, but rather to choose full description. And remember, we can also have absent connection when the right ventricle is dominant, and that is typically seen in hypoplasia of the left heart. And even when we have absent connection with dominant right ventricle, we can still have straddling and overriding of the solitary valve, giving us another variant, atrial, but biventricular connection. So this is the heart that we've already discussed this morning, when we have problems in determining whether this is tricuspid atresia or whether it is mitral atresia. What you see is that the right atrium is communicating through this right atrioventricular valve, and the blood is entering a dominant left ventricle with fine crisscrossing apical trabeculations. The pulmonary trunk is arising from this ventricle, but through the ventricular septal defect, the blood is entering an incomplete right ventricle that is positioned superiorly and leftward on the shoulder of the ventricular mass. And that incomplete right ventricle is giving rise to the aorta. But there, when you look into the floor of the left atrium, you see that there is complete absence of the left atrioventricular connection. And morphologically, when I look at that left atrium, for all the world, this looks like what I would call mitral atresia. And if I was only shown the left atrium, indeed, I would be calling that mitral atresia. But I know that by inference, looking at the rest of the heart, which you have already seen, that intuitively, had a valve developed between this left atrium and the incomplete right ventricle that is positioned leftward and superiorly, that valve would have been of tricuspid morphology. So I can see every reason why you might want to call this tricuspid atresia, but if you call a blind ending left atrium tricuspid atresia, I think you're going to confuse a lot of people. So I reiterate, my own preference is to opt for full segmental description, usual atrial arrangement, absent left atrioventricular connection, right atrium connected to dominant left ventricle, incomplete right ventricle in leftward and superior position, and discordant ventricular arterial connections. And so this, rather than being tricuspid or mitral atresia, is better described as of the left atrioventricular connection. Now here's another interesting heart. As you look at that floor of the right atrium, I defy any of you to tell me what is going on at the ventricular mass, because for all the world, that is classical tricuspid atresia. But in fact, in this particular heart, when you look at the left atrium, you see that there is straddling and overriding of this left atrioventricular valve. And in this particular heart, the left atrium joins both the left-sided morphologically right ventricle and the right-sided morphologically left ventricle. And Andrew has shown you this heart. And intuitively, again, you can argue that had a valve developed from that right atrium to the ventricular mass, it would have been of mitral morphology. So, once again, when we have complex situations, we need to opt for full segmental analysis. Because we can also have the situation when there is absent atrioventricular connection, and the straddling and overriding valve is found in the presence of right-hand ventricular topology. And so in this instance, it truly would have been tricuspid atresia. The bottom line, when we have these complex arrangements, the only way we can provide rational description is full segmental description. And finally, remember that we can also have absence of the atrioventricular connection or atrioventricular valvar atresia as part and parcel of hypoplastic left heart syndrome. And here in one of Andrew's exquisite casts made from a fetal heart, you see there's hypoplasia of the left ventricle with a dominant right ventricle, in this instance in the setting of a ventricular septal defect, but the cast shows you beautifully absence of the left atrioventricular connection. And we can show that. And here, the classical hypoplastic left heart syndrome, absent atrioventricular connection, slit-like left ventricle with intact septal structures, dominant right ventricle. They are all functionally univentricular, and they also have one variant of atrioventricular valvar atresia.